Let's move to the next talk, and it's going to be left main PCI versus CABG, and this is going to be by our friend from Tunisia, Dr. Habib Gamra. He's a senior interventional cardiologist and one of the founders of interventional cardiology in Tunisia. Dr. Gamra, please.
Thank you very much, Chairman. Thanks to the organizing committee of GIS and Abdullah, particularly, and all the members of the board. I'm glad to be here participating in this prestigious meeting to talk about left main PCI versus CABG, two different procedures. They have no disclosures. So if the title of my presentation was the question whether these two procedures are different, yes, indeed, they are two different procedures, and you can see the difference. Now, that difference does not justify a conflict between cardiac surgeons and interventionalists that has been going on for many years. And it has reached, actually, the news, the media, where actually you have BBC talking about it in December 2019, and then this is TCD-MD talking about that conflict too. The conflict is related to the fact that one of the famous surgeons who is representing cardiac surgeons in the steering committee of the Excel trial, he decided to withdraw his name from the authorship of that trial in a big journal, which is the New England Journal of Medicine. And the surgeons, they have decided to do not support the guidelines of cardiology in terms of management of left main PCI. This is a debate that's going on despite the fact that the first procedure of PCI in the left main was performed 45 years ago by Andreas Grenzi. Now, until now, the debate is not over, but it has changed. Now, what we know is that both techniques are valid and here to stay. The fundamental question is when PCI and when CABG is appropriately selected and indicated. Of course, all left main stenosis are not alike, and you can see that a stenosis of the ostium or of distal left main are not the same. For the ostial lesion, we go very fast. This is a very fast procedure. You can place only one single wire, predilatation, stenting, and the procedure is over after a few minutes. Now, it is the same for the midshaft, where actually you can achieve excellent results just after a few minutes of procedure. And that's explained why actually Andreas Grenzi was his first left main was a midshaft stenosis of the left main. Do we have evidence? Yes, we do. We do have a multi-center registry that was published in the first time in 2014. It has compared the long-term clinical outcome after PCI versus CABG in patients with ostial or midshaft lesions of obstructed left main. And this is the scheme of the registry. The results are very clear. There is no difference at 3 years of follow-up in terms of all-cause death, MACE, death and MI, or all-cause death, MI, and CVA. And the conclusion is very clear, a comparable long-term results between the two approaches for this kind of anatomy, despite the use of older first generation of EDAS. That same multinational registry was revisited just a few years in 2019 with the use of new generation drug-eluting stent, and the conclusion was the same. In fact, it's not that lesion where the debate is. The debate continues about this kind of anatomy, and unfortunately, this is the majority of anatomy of left main. Now, guidelines have very rapidly evolved in terms of the role of PCI in this kind of anatomy from 2001 and 2005, where it was class 3. Things have very rapidly evolved, and in the 2018 ESC guidelines, we could find actually a niche for PCI for left main disease with low and intermediate syntax score. Where the guidelines come from? What's the evidence that we have in 2022? And I will take you in a very quick trip and review about the evidence from the syntax side that was published at 5 years in 2013, showing similar outcome at 5 years in the left main subset of the syntax trial, with two differences: more CVA with CABG, more revascularization with PCI. Now, 2016, two major trials. The Excel trial, I will go very fast, and you might remember two trials presented in the same meeting, but completely different conclusions. Excel at 3 years, similar rates in the primary endpoint between the two approaches, and PCI might be considered as an acceptable or even preferred strategy. At 4 years, almost the same, and then Noble in the same meeting, once again, completely different results. At 5 years, better results in terms of primary endpoints with CABG versus PCI, but no difference in mortality. However, more MI, no procedural MI, more stroke, and that's maybe the only trial that has shown more stroke in PCI, and obviously more repeat revascularization. The conclusion of Noble, CABG was superior to PCI, but there is no difference in terms of mortality. The same year, a few months later, a meta-analysis, including, by the way, Noble and Excel, in addition to syntax. And the conclusion of that first meta-analysis is that in low surgical risk patients, these two approaches are equal, with, however, more repeat revascularization in PCI as expected. Few months later, after a few years later, 3 years later, the 5-year outcome after PCI of Excel, and that was actually the issue, the problem, where actually David Taggart has withdrawn his name from that particular paper. And what you can see at 5 years, there is a trend towards more events in terms of death, stroke, or MI with PCI, but it has not reached the statistical significance. Again, in low and intermediate syntax score, that was the conclusion of syntax at 5 years, similar results between the two approaches. And thus, PCI still remains an acceptable revascular modality in selected patients with left main stenosis. More recently, less than 1 year ago, two meta-analyses, the one published by interventional cardiologist Mark Sabatine, more than 4,000 patients, primary endpoint in terms of all-cause death, no difference, 0 to 5 years, 0 to 1 year, 1 to 5 years. But however, in terms of secondary endpoints, more spontaneous MI with PCI, but more procedural MI with CABG. Repeat revascularization as expected, more with PCI. The conclusion is there is no statistically significant difference in 5-year all-cause mortality, but there was a trade-off in terms of the risk of MI, stroke, and revascularization between the two approaches. Almost at the same time, another meta-analysis published by our surgeon colleagues, and almost including the same trials, showing at 5 years, in terms of mortality, no difference. In terms of MI, this favors CABG. In terms of stroke, no difference. And in terms of repeat revascularization, of course, favors CABG. But let's go into the details. Going into the follow-up, 30 days, 1 year, 5 years, no difference in terms of all-cause mortality. However, in terms of MI, 30 days, no difference. At 1 year, no difference. But more MI, spontaneous MI, at 5 years in the PCI patients. In terms of stroke, 0 to 30 days, this favors PCI. At 1 year, this favors PCI, but at 5 years, no difference. And in terms of repeat revascularization, of course, this favors CABG. Conclusion of that meta-analysis is that patients with left main coronary artery disease treated with either PCI or CABG do not show significant difference in early or 5-year mortality. Although CABG was associated with high stroke rates at 30 days at 1 year, PCI was associated with an increase in MI and need for repeat revascularization at 5 years. So no difference in mortality, trade-off in terms of events at follow-up. So the evidence is quite clear, but the decision is not always easy. And that is actually where comes the importance of the heart team. And the patient, of course, should be more and more involved as suggested in the most recent guidelines of the ACC-AHA. Now, there is something that is really important, and I really like this slide, that shows actually the perception of an event by the patient versus by a trialist. And for instance, for a trialist, what matters most is death in a trial. However, for the patient, what matters most is MI or stroke, more than death. So this actually emphasized the role of the patient opinion in terms of decision making. Very few examples. When PCI is a better option, this is a patient, 73-year-old, diabetic stroke with no sequelae a few months ago, RCA free of significant stenosis, high syntax score, 38. You can see that poor runoff, of course, in addition to the left main, we could not send that patient to surgery. We did have to proceed with what Antonio Colombo likes to say, to call massage of the distal runoff with just drug-elutic balloons and then left main stenting, and this is the final result, which is quite acceptable. When CABG is a better option, this is another patient, 65-year-old, diabetic, previous stenting of the LAD and RCA, very high syntax score, 45, and acceptable enough, the patient was sent to surgery with a good result. When neither is an option, this is an 83-year-old patient, multiple risk factors, severe angina, where actually we could not cannulate the RCA, and we can cannulate the left coronary artery. I might need 1 minute, please, if that's possible, before interruption. So in that particular patient, we have a left main stenosis, but we cannot see the bifurcation, LAD, LCX. So we could not proceed to perform the procedure. We could not cannulate the RCA. So he elected in that very old patient to go with medical therapy. So sometimes you just cannot go ahead with surgery. You cannot go with PCI and just go with medical therapy. Just my conclusion.
1 minute, yes.
Thank you. It's not working. It's okay. So in practice, this is a guidelines of 2013, but I really like it because it's quite simple. So in patients with mid-shaft and high mid-shaft left main stenosis, high surgical risk, this patient is an extreme, will go to PCI. The other extreme, patients with syntax score more than 33, low surgical risk the patient would go to CABG. In the middle, this is the hard team discussion that is really important. This is the most recent guidelines of the ACC-AHA I just passed, which is really important in decision-making, is completeness over revascularization. You know the difference. It's a completely different outcome when you go ahead with a complete revascularization. So in conclusion, there should not be a conflict between the cardiac surgeon and the interventionist in the management of patients with left main stenosis. The concept of heart team should be more widely implemented, and there must be more role with the patient in a patient-centered approach. Thank you very much for your attention.
Thank you. Thank you very much, Dr. Habib. For sake of time, because we will have a live transmission later,